I'm really honored to introduce Dr. Danielle Martin. She's a family physician and associate professor in the Department of Family and Community Medicine, the Institute of Health Policy Management and Evaluation, and the School of Public Policy and Governance at the University of Toronto. She practices in the Family Practice Health Center at Women's College Hospital, where she is also Vice President of Medical Affairs and Health System Solutions. Dr. Martin's policy expertise and passion for equity have made her a leader in the debate over the future of Canada's health system, as well as abroad, where she has notably testified before the U.S. Congress. In 2017, she was asked by the Federal Minister of Health to participate in a national review of 8 major federally funded pan-Canadian health organizations to make recommendations for their future. A strong advocate for removing barriers to care, in 2013 she co-founded the Women's College Hospital Institute for Health Systems Solutions and Virtual Care, a real-world solutions engine dedicated to solving the health gaps in the Canadian health system. She should come down here and help us. We've got a few gaps of our own, quite notably. She holds a Master's of Public Policy from the School of Public Policy and Governance at the University of Toronto. Her best-selling book, Better Now, 6 Big Ideas to Improve the Health of All Canadians, was released by Penguin Random House Canada in January of 2017. As a practicing doctor, a hospital administrator, and a policy expert, Dr. Martin offers a unique perspective on health system change. She appears regularly as a medical contributor on CBC television, is a columnist for Chatelaine magazine, and is an in-demand speaker on a variety of health and healthcare topics nationally. I'll add that Dr. Martin will be signing copies of her book during the upcoming poster session. Welcome, Dr. Martin.
Thanks so much. Thank you, Mark, and for inviting me this morning and for bearing with me as I discovered there are 2 Hiltons in the city of Chicago. And I do not think that the participants at the conference at the other Hilton were particularly interested in my talk. So I'm so grateful, especially grateful to be with all of you here this morning. I have such tremendous respect for the role that primary care research plays in our health systems. It's work that I draw on every day in my own work to try to better understand what kinds of reforms should we be pushing for and working towards each in our own spheres of influence. And I will also say that as much as I admire the content of the work that is produced by the people in this room, I also draw inspiration from the extraordinary people who do it. There's a certain kind of person I aspire to be, and it's a phenotype that I think is rampant in this ballroom this morning. It's the kind of person who is able to hold both their values and a commitment to evidence simultaneously as a form of what I like to think of as emotional and intellectual ambidexterity. And of course, while all of us here today are strong believers in science and evidence-informed care and evidence-informed policymaking, we all also know that no decision can be made on the basis of evidence alone. Values are always an important and relevant input to every kind of decision that we make. In healthcare, in order to move from concepts and big ideas of the kind that you all trade in to action, we've got to do a lot more than just stick to the facts. We have to figure out how to make those facts relevant and relatable. We have to speak about and interpret the evidence in ways that connect not just with our brains, but with our hearts. And I suspect that I'm not alone in this room in my struggle about that these days, because I'm worried about how values-driven decision-making is being carried out in what sometimes feels like a post-truth era. There was a report recently released by an organization called the Pew Research Center that found that after completing a skill testing quiz, about 1/4 of Americans can differentiate a fact-based statement from an opinion. 1/4. So, and older adults, I'm sorry to say, fared worse in this game. And a whopping 1/3 of 18 to 49-year-olds could correctly differentiate between a fact and an opinion, while just 2 in 10 adults over the age of 50 were successful at differentiating the two. So that's a problem, right? I'm going to go out on a limb and say that's a problem. But we all know that the answer is not to yell facts more loudly at people. Any more than in our offices as primary care providers, the answer would be to yell more loudly at people that they should lose weight or quit smoking or do any of the things that they should do. But it's hard to know, how do you combat the rise of worldviews that put peer-reviewed research on par with celebrity opinion, or evidence-informed policy briefs on par with random tweets? But the reality is that's the space we're operating in, and I think that that's the challenge that we as a community of primary care researchers and practitioners face. So as a person who's actually long believed in the importance of narrative and values, that they deserve a place in the scientific discourse, but doesn't believe that we should make science subservient to stories, what I want to try to explore a little bit together this morning is that elusive place where I'm hoping that our values and the evidence and action intersect. And I want to share with you some learnings from the last 18 months of my own life, where I've been trying to explore that intersection through the use of this book that was mentioned earlier. I want to sort of lift the hood of that process and describe to you what it's been like for me to be out there with this book, what I was trying to do with it, and where I failed and where I succeeded in my mission. So I wrote this book, and the goal of the book was not to produce a book per se, but it was to have a product that I could use as the basis for a public engagement campaign. The idea was that I was going to try to push these 6 big ideas that I believe could make a real difference to the health of Canadians, although I should add in parentheses that I think that all 6 big ideas are just as applicable here in the US and elsewhere internationally. And I basically spent 18 months traveling all over Canada. Somehow, even though it was a year and a half, it was always snowing, and I was always on the tarmac getting the wings de-iced, going across the country and giving talks in libraries and community centers and high school auditoriums and doing the morning shows on talk radio to try to engage regular Canadians, not learned erudite people and not policymakers and not decision makers, but citizens in a conversation about these big ideas, which included, and the very first one is the importance of relationship-based primary care. Other ideas included the need to reorganize our resources in healthcare to reduce wait times without spending more money, and the concept of a basic income guarantee as a health intervention, a nod to the link between public health and primary care that we were just exploring. So I will say that I believe that each of these ideas is grounded in solid evidence, but the way that I framed them was around patient stories. And I had this experience of working with a professional editor who essentially said to me when she read the first draft of my manuscript, these stories are great about your patients, but there's a character missing in your book, and that character is you. And so I was pushed to provide my own story about who I am and why I've come to pursue the things that I care about in the book. And so the very first story, the one that opens the book, and it's now a story that I've told over and over again, probably hundreds of times in public settings like this, so many times, in fact, that I know that many of my Canadian colleagues have heard me tell this story before. I've told it to financiers, and I've told it to seniors groups and Rotary clubs. I'm going to share it again with you today because I want to explain to you why I chose to use it and why I chose to make myself vulnerable in this particular way. So the story begins in December 1951 with my grandparents, Jacques and Sarah Shilton, who arrived in Canada at Pier 21 in Halifax, Nova Scotia, which is on the east coast of Canada. They had come from Cairo, Egypt, on a big ship with 3 generations and $200 in their pocket to try to start a new life. And you can imagine, by the way, what it's like to arrive from Cairo in December in Halifax. It was a shock to the system, and my mother, who was a little girl at the time, remembers the snowbanks towering over her head. To her, they seemed like mountains of snow. They had left behind nearly everything and everyone they knew. And essentially what they had brought with them was a few $100s and several trunks of totally inappropriate clothing. So they got on the overnight train to Montreal. My family spoke French, and they began to build a life. And it was clear that the burden of that process of building primarily fell on the shoulders of my grandfather, Jacques, who was a very educated man. He spoke 7 languages. He was very handsome. He was big and tall. He had an air of authority, and he was an optimistic person. And they knew it wasn't going to be easy, but he was up to the task. Suddenly, only a year after arriving in Montreal, at the age of 41, younger than I am today, he suddenly and unexpectedly had a massive heart attack. He'd actually gone to visit a friend at the Jewish General in Montreal. I don't know how many of you have visited Montreal, but there's some kind of a zoning law that every hospital must be built at the top of a hill. So he climbed up this hill, and as he was waiting in the waiting room to visit this friend, he had a massive infarct. And as was done in those days, he was admitted to the hospital for more than 2 months. That ordeal obviously diminished him physically, but also in many other ways. There was the stress that came from not being able to work, which of course meant failing to support his family, and the cost of the hospital stay, followed by the ongoing costs of prescription drugs and visits to doctors and cardiologists, became more than they could bear. My grandmother then had to endure the twin pressures of caring for an ailing husband and trying to hold together a family with 2 little kids that was under severe financial pressure. And she was forced to borrow money from relatives, money that she was never able to pay back, and that amazingly, although I'm sure you'll all understand how these dynamics work in families, still 2 generations later, the rifts in the parts of the family continue to exist. But she didn't have a choice. She couldn't fail to borrow the money, and she couldn't pay it back. Any of us would have done the same thing. My grandfather ultimately went on to have several more heart attacks, which further limited his ability to work, and Sarah, his wife, eventually succumbed to the pressure of it all and was herself admitted to hospital, having suffered what was known in those days as a nervous breakdown. The stress had basically just worn her down. 15 years after they came to Canada, my grandfather died. He was 54 years old, and the year was 1966. The very same year that Canada's federal government first moved to create universal health coverage, otherwise known as Canadian Medicare, across our country. Now, that story may not be particularly shocking to you, particularly our American colleagues. I know that it hits particularly close to home, here where you're continuing to work today towards universal health coverage. But that story is unheard of, essentially, in Canada today. And when I tell it across the country, I get gasps of horror to imagine that a family could lose a home due to medical bankruptcy is, essentially in my generation, something that people don't believe, it's not congruent with their values, and it's just not something that happens in Canada anymore. And every time I tell it, I finish with the same rhetorical question. How different would life have been for my grandparents and for my mother, who has had to carry this story like a stone her whole life, if Canadian Medicare had been in place just a generation earlier? And the answer is, it would have changed everything. So that story didn't just shape my family history, it shaped my perspective. In Canada, we've now created single-payer systems of healthcare across our country for doctor and hospital services in response to some fairly fundamental questions. And they're not questions about evidence, although all of the international evidence supports that single-payer systems are more equitable, less expensive, and provide better quality care across populations. We've created those systems not because of that evidence, but because of the fundamental values that underpin the questions like, should we be there for one another when we're at our most vulnerable? Do we place well-being above wealth? Do we believe that good health leads to other good outcomes, like stronger economies, more cohesive communities, and more fulfilling lives? So before we even begin to talk about evidence, we have to be clear about our shared values, and then we turn to the evidence to answer our questions about how best to design systems that help us live up to those values. So as a family doctor working in the Canadian healthcare system, I actually believe that we have a lot to be proud of. But I am not an advocate for the status quo. We have very significant challenges in our Canadian health systems that have to be confronted, and some of you in the room may have seen the special issue of The Lancet that came out earlier this year that was devoted to the Canadian healthcare system, which I had the opportunity to work with colleagues on from across the country. And one of the things we were asked to do in that issue was to articulate the major challenges in Canadian healthcare systems for an international audience. And based on the best available evidence, we chose 3. The first is that Indigenous health disparities in Canada are unacceptable. The second is that wait times for elective care are too long. And the third is that access to services outside the core basket of Canadian Medicare, which is doctors and hospitals, is too uneven. And so one of the things I hope to do today is to challenge my colleagues in Canadian primary care research to ask yourselves, if you agree that the evidence says that these are the 3 biggest challenges we face as a nation to our health in our healthcare systems, are we focusing on the right kinds of questions or the aspects of those questions that primary care research can help us to better understand? So all 3 of those issues would meet any definition of a critically important problem by quantitative or qualitative metrics. But all 3 of them are also threats to Canadian values. And I believe that they need to be framed as such if we're to see action on them in our lifetimes. So how do you do that? How do you connect to people's values in ways that are consistent with evidence, but that go for the heart? Well, to do that, I believe you need to tell stories, which is why I share so many in my book. And the first one is the story of a patient I call Abida. I want to tell you the story, again, mostly so that I can explain to you why I told it and what the reaction has been from it since I published it. When we first met in 2006, when I joined the family practice unit where I still work, she was in her early 60s. And even then, she was already what we call a complex patient. You all know what that means. She had chronic lung disease and bowel issues. She'd had many strokes, and she had a recurring set of vague symptoms: chest pain, pelvic pain, memory loss, frequent headaches. And she would frequently come in to see whoever the doctor of the day was with an urgent issue and get sent off to the emergency department because that person couldn't tell what was a change from her baseline, and everyone was always terrified she was having a heart attack. She spent her days in specialist's office, too many nights in the emergency department. She had access to a multidisciplinary team to help her manage her osteoporosis and a different multidisciplinary team to help her manage her chronic cardiac disease. She was basically a full-time patient. So that's what you could learn from her chart. But here's what you could only learn from getting to know her. Abida had immigrated to Canada many years ago after an arranged marriage in Bangladesh. I've known a lot of patients who have experienced long and happy marriages under such circumstances, but she is not one of them. Her home life was unpleasant and a source of constant stress, with a husband who was negative, demanding, and verbally abusive. I remember her once saying to me when she came in because she'd been having chest pain, I cooked all day, and when I put the dinner in front of him, he refused to touch it. Well, you don't have to wonder why she's having chest pain. As we came to know one another, it became clear that her health would suffer when things at home were worse. The grind of a difficult home life would reliably exacerbate and inflame her very real symptoms. And her specialists were all outstanding. They gave expert attention to each of her specific maladies. They were looking out for Abida's heart and Abida's lungs and Abida's hips. But who was looking out for Abida? I share in the book how, as her family physician, I got to know her slowly over time, and we began to experience together the rhythm of her well-being. Over time, we weaned her off some of the many medications she was taking, and we got it down to a necessary few. Her visits to hospital became less frequent, and when a new symptom emerged, I was increasingly able to track it both against her history, her baseline, which I had come to know and understand, and just as importantly, against the stresses happening in her life. Now, her health is by no means perfect today. She's aging after all. And in fact, things at home are worse today than they were back then. So this isn't, a story with a tidy, happy ending. And I've also made mistakes in her care, possibly even more than my share. But by getting to know her over the last 12 years, I am totally confident that I've been able to give her better care than she would have had if we did not have more than a decade's worth of trust building between us. Well, I don't have to tell this group what the takeaway is from ABITA. It's supported by all the international evidence that people like Barbara Starfield and generations of primary care researchers in this room have helped to amass. It's that relationships have a direct and often sizable impact on health and wellness. And all of the research that points to the importance of primary care in equitable health outcomes and controlling system costs and reducing harmful and unnecessary care, and the list goes on and on, I believe comes back to that elusive notion of the relationship. So here's my second challenge to the room in terms of knowledge gaps. How well do we understand what it is about relationship that delivers these improved outcomes across populations? And might this be an area where we need to dig a little bit deeper in order to understand how to build the best possible systems internationally? And so we know this, and we've had this evidence for, decades, and yet we're still struggling in Canada to ensure that every single person has access to such a relationship, even though more or less everybody is covered. As someone who had spent a lot of time on government committees and organizational boards trying to convince decision makers that universal access to a relationship-based primary care was critical, I was really getting sick and tired of the slow pace of system change. So I made a decision to stop spending my time trying to convince decision makers and instead to talk to the Canadian public. And I used ABITA's story as an entry point to try to connect with people's own experiences with primary care, hoping that this might somehow contribute to a movement among citizens for the change that we need to see. And I have to tell you, I was nervous about it. I was specifically nervous about ABITA and about this notion of relationship-based primary care for every Canadian, because it felt a little airy-fairy to me. It wasn't as concrete as some of these other ideas I was putting forward, like we need universal pharmacare or we need a guaranteed annual income. I was worried that people would sort of say, well, what is this relationship stuff? I mean, we don't even know how to measure it. How would you say that everybody has a relationship with a primary care provider? And I have to say, I was totally wrong. People get it. They get it immediately. They intuitively understand what it is that this story is trying to illustrate. And it's the big idea that people come back to over and over again, that they stop me to say, I read your book and I still think about that woman with the family doctor and all the emergency department visits and all of this stuff, because everyone who has experienced high-quality relationship-based primary care immediately knows what it feels like, and everyone who hasn't feels the lack of it in their lives. So telling stories, it's an important way and a powerful way to motivate people to get behind evidence-based or evidence-informed change. And I didn't, make this up. Marshall Gans, a person whose work I'm sure is familiar to many in the room, who's a longtime United Farm Workers organizer and now a professor at the Kennedy School at Harvard, has proposed a theory of what he calls public narrative, which brings together three stories: the story of self, the story of us, and the story of now. And this is going to start to explain to you why I have approached this in the way that I have. So the story of self is a personal story. It's your own story. It's what the story that Gans says illustrates, and I quote, why you were called to what you have been called to. It's the one that makes you human and contextualizes you in the work that you're involved in. It may be the experience that first made you think, I want a career in health research, or I want a career in primary care. Second, there's the story of us, which illustrates the shared purpose or goals of a community, a movement, or an organization. And NAPCRG is such a community, right, that comes together around shared goals. And so there's a story of us, of what we're trying to achieve together, that is extremely important. And then finally, there's the story of now, the story that communicates urgency and a challenge that has to be overcome, and that gives people hope about what it is that we can do. And it's when you bring those three stories together, when you link the story of self, the story of us, the story of now, that you have a powerful tool to ignite social change. And I'm sure I don't need to point out to all of you the role that evidence and research can play in the construction of each of those stories. So that's what I was explicitly trying to do with this approach in a book and a tour across Canada last year. I shared the story of self that I have just shared with you, not for a random reason, but specifically to try to situate myself, who I am and what it is I'm trying to achieve and why. I then shared the 6 stories of us. 6 people, real people, who I call Abida, Ahmed, Susan, Sam, Leslie, and Jonah, whose experiences illustrate the challenges that we face to improving health. And on the tour, I tried, and this is where I feel I failed, to connect to a story of now, asking people to help me to advocate for relationship-based primary care, universal pharmacare, the elimination of unnecessary and harmful tests and procedures, better organization of the resources we have in our systems, the elimination of poverty as a determinant of health, and the spread and scale of successful models of care. Those were the 6 big ideas, and each was linked to a human story. I learned a lot over those 18 months, and there are 2 things that stand out for me that I think may be useful to you in your work as researchers. The first is a lesson about narrative, and the second is a lesson about action. On the question of narrative, I think we often talk about, and most people in this room would be respectful and talk about the role of narrative. It's a very important tool that we use in communicating research, but we often talk about it and I think conceive of it as sort of a one-way street. So we have research findings and then we use a story to communicate why those findings matter or why they're important. We use them to communicate in the media about why it is that people should care about the findings of our research. Or we use stories to illustrate the importance of a research question to a granting agency in order to get our grants. So the use of narrative or stories is very much about one-way communication. It's a communications tool as opposed to an engagement tool. But here's what I learned last year. Once you open the door to the story of us, people will come to you with their own stories. I have now dozens and dozens of them. I get them by email, even still this week. I get them through social media. I get them handwritten on beautiful letters and cards being sent to me across the country. Some of them have brought me to tears of pride, and others have filled me with shame. Like the story of a retiree from British Columbia who awoke one day having abruptly lost vision in one eye. That very same day, he was rushed into an emergency surgery that in all likelihood saved his life. Instant care, a positive outcome, not a single bill. Our system in Canada at its best. And every Canadian knows someone with a story like this. But then there was the man from my home province of Ontario who reached out to tell me that he was so grateful, he's very Canadian, so grateful for the world-class treatment he received for both the heart attack that he had had and the cancer that he had survived. But the chemotherapy had caused horrible sores in his mouth and problems with his teeth. And he was a construction worker. He didn't have any employer health benefits, and so he couldn't afford to see a dentist. And so for months, this man had not been able to eat solid food. And he wasn't emailing me to complain, by the way, he was emailing me to ask if I knew a dentist who might be willing to put him on a long-term payment plan so that he could pay it off bit by bit, month by month. This same man, having suffered a heart attack, would of course significantly be able to significantly lower his risk of a second MI by taking the usual cardiac cocktail of medications that we're all very well aware of. But because through an accident of history, Canadian Medicare doesn't include prescription drugs, which is a problem that I talk about in depth in the book, most months, this guy just has to roll the dice. So what I'm trying to say to you is that it turns out that narrative is a two-way street. When you use a story as a means of connecting with people in a way that is truly meaningful, and when you call them to action, one of the actions they will take, even without your having to ask for it, is to bring you back their own stories. And they use that as a way of testing reality to see whether their story is consistent with what it is that you're trying to talk about, and they'll also use it to challenge your perspective, to say, actually, what you said doesn't ring true with my experience. Here's what my experience has been. And yet, I don't think that we often use stories in this way in primary care or in primary care research, which is a shame, right? Because the relationships that we build in primary care are the perfect substrate for that kind of narrative dialogue that I believe is needed to make social change. The second lesson that I learned was a lesson about action. And this is the second time this week I've told this story. It's one of my favorite moments in my whole 18-month, odyssey. It came to me courtesy of a group of retired nurses who showed up at a book event that I was participating in. And this group of 5 or 6 women have a book club. And so they actually showed up to my book launch, but they'd already read the book. They each had a copy under their arms with little multicolored sticky notes sticking out the sides of it. In this incredibly practical way, they came to say to me, "We read your book, we agree with your ideas, what do you want us to do?" And this is where I faltered. And I should have anticipated the question, really, because I clearly remember Marshall Gans saying at a talk I once heard him give about public narrative, you cannot get people all excited about an idea and then not give them anything to do. Once you progress from the story of self to the story of us to the story of now, you have to expose for people their own power to make change, which is why he would say, and that's why, before you leave the room today, you need to sign XYZ petition, or that's why we're meeting on Monday afternoon at 4 to do the demonstration, or whatever it is. And I was not totally ready to answer that question from these nurses. I didn't have a petition for them to sign. I didn't have a donate now button for them to click. I didn't have a committee for them to join. I was a single individual doing what I could, and I had thought through the notion of trying to raise people's awareness, and lots of, I think, good work has come out of that. People have come back to tell me that they did this or they did that as a result of it, but I did not have a well-coordinated campaign or a movement for them to join. And I think that what's clear is I can't do that alone. So we're going to need, together as communities of researchers and providers and health systems leaders, to figure out what the changes are that need to happen with the engagement of our publics, and then we need to give them something to do. So how does all of this relate to the work of primary care researchers? Well, I suspect, I could be wrong, but I suspect that many people in this room have experienced the frustration of seeing your work fall short of making an impact, in part because you made the mistake of thinking that evidence is enough to drive change. That may be especially untrue at this moment in history, but actually I think if we're honest, it's never really been true. Nor would we ever really want it to be. A world driven solely by evidence in the absence of values would be a very poor world indeed. So people who believe as we do in the importance of evidence need to also use narrative and narrative dialogue to link to values and then to action in ways that draw not just on storytelling, but on the principles of community organizing. So that's a challenge to primary care research. Are we clear on what actions need to happen and on who can take that action? I think we can start by asking what issues and problems are ripe for international collaboration in a room of extraordinary global researchers in primary care like this one, and for cross-national action among citizens who care about health. Let's try to find those places where the evidence and the values intersect at pressing problems that require not just research, but action. And I want to speak very briefly about one realm in particular where I think that there's a need for that, and that's in the world of pharmaceutical policy and pharmaceutical research. This is an area where every country in the world is struggling to figure out what we're going to do with the rise of high-cost medications, with the absence of universal coverage both in Canada and the United States, with the new US-Canada-Mexico trade agreement that has further extended patents in North America. And people are organizing around these concepts intuitively because they understand how critically important these issues are. This past May, the Right Care Alliance here in the US organized an Insulin Day of Action on Mother's Day, and they created the tagline, "No mother should have to bury her child because she can't afford insulin." They held rallies across the United States, and families came out to show their support. They've got a website and channels, social media channels that are filled with photos of people who are impacted by the decisions that are made not just by drug companies, but also supported by government policy. In Canada, the Canadian Labour Congress has created a campaign for national pharmacare to try to bring prescription drugs under our single-payer plans. That campaign is called A Plan for Everyone. And they've been holding town halls across the country this past year, asking people to come out if they support a national pharmacare plan in Canada. So I use these as examples because I suspect that many people in this room are engaged in research that in some way, shape, or form bumps up against pharmaceuticals. And yet I don't know how many of you are aware of the organizing that's going on across the country among people who care about these issues, and how many of us are intentionally linking our work as researchers to that kind of community organizing. And I should say that we would be fools to think that those who are pushing for higher drug prices are respecting national borders in the work that they do. You cannot seriously expect the government of Prince Edward Island, or even the government of Denmark, or even the Veterans Administration to sit across the table from a Pfizer and expect to get any traction. If the companies that are engaging in this space are multinationals, so too must be the movements of research and action be global movements as well. Whether we're talking about better ways to manage chronic disease, to care for aging populations, or eliminating barriers to accessing care for people in rural and remote communities, it's at that intersection of evidence and values, of research and action, where I believe we can truly make a difference. So in conclusion, it seems to me that the question we all have in common, no matter where we live, is whether our shared values and the power of the evidence we generate can be effectively channeled to challenge the established order, to move beyond rhetorical debates and deliver real and meaningful change to people who need health care every day, not just in the ways we pay for care, but also in the ways that it's delivered. And I get that this feels like a really big task. And I get that you may think that you went into this career because you wanted to do research, and maybe it's somebody else's job to worry about how we're going to get that research taken up into the ways our systems are designed. But I think that that would be a mistake. If you don't think that big change can happen, I would ask you to remember the story I began with this morning. I am sure that my grandmother, Sarah, could not ever have imagined that her granddaughter could become a doctor, or that I would never have to ask a patient for money before treating them. But the people of my country made that happen. And they did it over the protestations of many elected politicians and many doctors and plenty of powerful actors. And they made it happen not as patients or providers, but as citizens. Surely it is possible for us in our lifetimes to achieve something just as bold. The ambidextrous research community, committed to values and to evidence, is a good place to start. And I'm here to tell you that you won't be alone. The Nurses Book Club will be there to help. Thank you. Thank you. Thank you. Thank you. I've intentionally left a good chunk of time here because my favorite part of these opportunities is always to engage in a dialogue and an interaction. So there are microphones around the room. If people are willing to kick us off in a conversation, that would be great.
Hi, Richard Young, John Peter Smith, Fort Worth. Great talk. I had a just brief background and a question. I'm a huge fan of the British national health system, not because it's socialized or nationalized or any of those imprecise words, but because I believe there's a sense of shared sacrifice amongst all the players in the system, the patients, the hospitals, the administrators, all that. What, to my ears, Iona Heath uses the word solidarity, that I think is that concept. And so my question is, in your conversations and hearing these stories, what I didn't hear in your talks was how often did the sense of shared sacrifice come up? How often did people offer up, well, if we're going to improve indigenous health, here's something I'm willing to give up or change to achieve that. Same thing with pharmaceuticals, right? I mean, if you're going to spend lots of money for one drug, well, it's money you can't spend for something else. So how did your stories help frame how that might work out?
Yeah, it's a great question, and I would point to, and I know there are people in the room here who do, participatory research in a variety of different ways. What I find amazing is how open, certainly I'll speak for Canada, how open Canadians are to these conversations about trade-offs. And it's one of the reasons actually why, although we have a problem with wait times for elective care in Canada, people will often, you'll often hear sort of in the hospital hallways or whatever, of a patient whose surgery had to be canceled because a trauma came in or whatever, and people will immediately intuitively say, well, that's very inconvenient for me, but of course the person who got hit by a truck had to be taken to the operating room before I did or whatever. And so they actually are willing to engage with those trade-offs in very personal ways, I guess is what I'm trying to say. But there was an exercise that took place in Canada in the early 2000s, a royal commission on the future of healthcare that was led by a former premier, Roy Romanow of Saskatchewan, and he carried out public engagement activities across the country. So not just traditional kind of town halls, but they actually would put people together in groups and they would give them, 100 Romanow bucks. You've got $100 to spend. And they would carry out these shared prioritization exercises. And I've heard him speak very powerfully about what that was like. I mean, people are actually very capable of having those conversations about trade-offs. I think that the trick is, and this links to some conversations that we've been having elsewhere this week, that you have to engage them not as patients, but as citizens. That's the difference, and so what you're asking them is, what kind of a world are we trying to build together? And if X drug costs, $1 million per QALY, and with that amount of money we could immunize all the children of the country or get clean drinking water to every reserve in the north or whatever, how are we going to engage in those trade-offs? They need to put their citizen hat on. If they come to the table as a diabetes patient wanting the expensive insulin, those conversations tend not to go anywhere. And so I think there are ways to engage people in those trade-off conversations, but you have to frame them, I think, quite thoughtfully. Hello, Rick.
Hi, Danielle. Wonderful, wonderful talk, as always. I've had the privilege of hearing Danielle twice in 3 days now, which
Sorry
is
about
fantastic. No, and many times before, and they've all been fantastic. I'm Rick Glazier from Toronto, family physician. I wanted to you've alluded to a lot of priorities. Most people in this room are primary care researchers, and your sense of what should be our highest priorities for our research. I truly appreciate your call to action and to examining our values, and I agree with all of that. But there are two huge kinds of research gaps in our field, which is relatively neglected research-wise. And the one gap is that we don't know what the evidence is, and another gap is we know what the evidence is and it's not made its way into practice yet or into policy. So I wonder if you have any reflection on either of those kinds of gaps or a particular kind of priority that you would like to come back to this meeting in a few years and see us really focused on, really building the knowledge base, whether it's the fundamental research, whether it's clinical or policy, or it's scale up, or it's implementation science, whatever it is. What would you love to see this group and all of us focusing on as priorities?
Thank you. So I would put out two areas for consideration of this group. The first is how do we, this notion of the learning health system that, now seems to permeate the literature, the idea that we should be collecting and using data both from kind of big data sources and from local practice-based sources to create a continuous loop of knowledge and learning within our health systems to improve care. I worry a lot that these constructs, which I generally think are, I support them and I think they're important and interesting, end up being very disease-based. It's just too easy to say, well, we're going to do something for people with diabetes, or we're going to do something for people with depression, or whatever it is. And so I think we need, as primary care people, to try to figure out how do we measure the impact of any number of practice-based or system-based interventions across diseases and instead in populations, and specifically to look for interventions that reinforce relationship. Which means that we have, I think, still a lot of heavy lifting to do to understand, like, what are the magic ingredients in a primary care relationship that actually make it work? And, beyond the kind of Starfield Cs and everything, how much continuity with individual versus team? What are the elements of quality that reinforce and uphold relationship? And if we can actually get a little bit more rigorous about defining what we mean by relationships and attaching metrics to that, then I think we will move towards a focus that is less kind of disease-obsessed and more holistic in its approach. And that is something that only primary care researchers, I would posit, are going to be really interested in doing. So I think that that's critically important. And then I think that the second area, well, maybe I'll stop there. I'll stop there and say relationships.
Hi, great talk, really inspiring. Jeff Borkin from Brown in Providence, Rhode Island. I was wondering, when you enter the world of narratives, especially at this time with competing narratives, how do you form with your group a cohesive narrative, whether it's around research or around public policy? And then how do you get your narrative heard?
Yeah, so thank you. I will confess that I began this journey in a pretty traditional sense. I already knew what evidence-informed policy changes I wanted to advocate for, and I used narrative as a tool to communicate those. And that's a pretty traditional, top-down kind of approach. I was the expert and I understand what we need to do, and therefore I'm going to find the stories that illustrate the point that I want to make, and then I'm going to go out and make the point, and people are going to get excited about. So where I learned, and what was, an enriching thing for me, was about this narrative loop, that actually I would put out my narrative and others would bring me back their own narratives, and I would have to shift my thinking as a result, with people saying, well, that doesn't totally work for me, or that wasn't my experience, or whatever it is. And that's where the real richness came in. So I guess what I would say is, this is where the evidence becomes critical. Like, I'm not interested in having a conversation about somebody's N of 1 experience in the public policy field. I'm happy to have that conversation in my office, about their own personal journey. But I am interested in narrative as a tool to advance change on shared issues that matter, which means we have to have a means of rigorously determining which areas of policy we want to go after. So maybe this is a second, having said I would stop on Rick's question, maybe this is a second area for us to explore. The micro-level practice-based change that we are all familiar with in the world of primary care is important, but the big policy levers have tremendous capacity to scale successful models. And I don't think that we have thought much or enough, perhaps in primary care, about what are those big levers of policy change, regulation, education, or whatever to really make transformative changes. And the narrative becomes then a tool for almost reality testing around whether we're headed in the right direction.
So thank you very much, Danielle. Hi, I'm Michelle Griever. I'm a family doctor in Toronto. I have a question, a story, another question. Question. When are you going to run for office? I would vote for you. Story. A lady called Sorrel King came to my hospital. Sorrel's daughter, Josie King, had been admitted for burns at Johns Hopkins Hospital. She was 18 months. A nurse gave her methadone while she was dehydrated, and Josie died 2 days later, right? Medical error. In the middle of her pain, Sorrel started a foundation. A foundation to prevent medical errors. It's called the Josie King Foundation, right? It's quite powerful. Many hospitals have started initiatives to reduce the likelihood of errors, etc. So that's my story. An individual can make a difference. Sorrel wisely worked through others. Here's the question. So my department has changed the name of our research program to Research and Advocacy. It is now Research and Advocacy. In terms of trade-offs, how do we better support advocacy within our departments? There's only so much money. You do have to make trade-offs. There's many competing aspects. I believe it is important. That's one of my values. You really have to do it. But then, what are the trade-offs, and how do we better support advocacy?
Thank you. So to your three-part question, I offer three-part response. When am I going to run for office? So, poor Rick heard me answer this question 2 nights ago. And what I find fascinating is how often people ask it to me. And so the short answer is I'm not running for office. The second part of that, the second part is because the reason for that is because I actually feel less encumbered and, if I can say this, more powerful from where I sit to make the change that matters most to me than I would be if I were, and I have tremendous respect for people who run for political office. I actually think I can make the change that I want to see better from where I sit. But I find it fascinating how often I am asked, and so this is my challenge back to you. Why is it that we always think that anyone who is an articulate advocate for a values-based set of changes is going to be a politician? Why aren't we all doing this? Why am I so unusual as someone who sits in the world of medicine and, sort of somewhat with a toe in the world of research and hospital administration? Why is it so unusual for me to be up here having this conversation with all of you? And so I think that we reinforce a problem about advocacy when we assume that people who want to do that advocacy work must have, not a political agenda, we've all got political agendas, but must have political aspirations. And so my hope is that, by the time I come back to NAPCRG in a few years, you'll all be up giving talks like this elsewhere, and nobody will think it's weird anymore, for people to do it in that way. Secondly, on this issue of trade-offs, because I agree with you, I think individuals can make a difference. And when horrible things happen to people, one of the ways that families can make meaning of those experiences is to translate that into, making the world better for others. What I would say is the trick is going to be for us to apply the same rigor to our advocacy that we do to our research. And then it's not a trade-off anymore, it's a synergy. Then people are just doing whichever part they're good at or best at. You hand the baton to me and I do the part that I'm good at and I hand the baton back to you and we're working together towards a shared agenda. It's not research or advocacy, it's all of us doing all of the things, research and advocacy and education and whatever, policy, in order to achieve the shared goal. And this is why I brought Marshall Gans to you today. Marshall, who I was introduced to partly through Pauline Pariser, who's in the room, because there is a science to advocacy too. It's not like we do the science and then we just run around screaming about making change. There are theories and structured ways of thinking about how to be effective as advocates, that we can apply our scientific brains to effective advocacy just as much as we can to the basic research. So that would be that's my dream. Thank you.
I'm Susan Phillips from Kingston, Canada. Hi, Danielle. So I want to go back to the idea of the importance of knowing the person, to that person's health. And this is something that I think everybody in the room wants to believe, and most of us have seen in practice. But when I go to look for the evidence base for that, it is non-existent.
Yeah.
And I can't say I look all the time, but I look for continuity of care and its impact on health. I look for all sorts of things, and I never find that evidence. Do you have any examples of it?
So this is my call to research.
do.
I agree with you 100%. You know, we sort of know access to primary care, you know, is associated with, you know, 1, 2, 3, 4, 5 excellent individual and system level outcomes. But when we start to break it down, I mean, why is it, I believe, I'll say, I believe that access to a walk-in clinic is not the same thing, for example. I'm just going to say that. Yeah. I go on a rant, by the way, about walk-in clinics in the book that talk show hosts love, because it's like they wind me up, they push a button and they just watch me go, right? But actually, I don't have a ton of solid ground to stand on when I say those things. And in fact, my understanding, the evidence on walk-in clinics is it's a little mixed, and actually sometimes and for some things, it's, you know, better than nothing, and maybe it's even better than access to your own primary care provider 3 days from now, et cetera, et cetera. So it's complicated, right? We need to define what we mean by relationship, because I believe that that's the umbrella term that speaks to this sense of being known, being seen, feeling, you know, someone is paying attention to you holistically. And we need to break that down into things we can measure and start measuring it, because otherwise, how are we ever going to build health systems that support those aspects, especially you know, health systems that are affordable and financially sustainable over time? Thank you.
Hi, I'm Liz Wickersham from Oklahoma City. And you brought up, I have been a major proponent for relationship-based care. I was in primary care practice for 15 years before I came to research. And when I came to the program I'm in now, I said, I see my own patients when they're sick. And they looked at me like I had 6 heads. And they're like, no, well, I'm sorry, that's how it's going to roll. But here's a question. So there's the whole issue of fragmentation of care, which we are really good at now in the United States. But now the conversation of putting a scribe in the room to help me deal with the EMR, that first came up last week with me. And I don't know that, I mean, I just am interested to hear, in my mind, I think that people are not going to tell me their stories. They're not going to share as much depth if there's another person in the room that they don't know. But I don't know that, and I wonder what it would be. It's freaking easy when she's typing and I'm just sitting there talking, but is that the right thing? I kind of don't think so, but I don't know.
This topic is hot, right? And those who haven't seen Atul Gawande's piece in the New Yorker last week, I guess, about how much doctors hate their computers, and, you know, the kind of albatross of documentation, and primary care physicians spending a zillion million hours per week, you know, clicking and toggling boxes and all of that stuff. So, I just came from the American Medical Informatics Association meeting in San Francisco. A room, by the way, where I understood approximately 33% of every word, you know, words that were coming out of people's mouths. But there's a lot of talk about this, right? Clinician burnout, and I think it's particularly acute in the American context because of the complexity of billing and insurance stuff that and all of the things that have to be reported out on. In the American context, that, you know, in Canada, I think when physicians complain about paperwork and computers and burnout in Canada, it's really hard for me to keep a straight face, because by comparison, what you folks are dealing with here is very intense. But I think it is real and it is true that people feel the loss of their connection with their patients, and they're going to feel it either because they're spending so much time engaging with the screen, or because somebody else is in the room engaging with the screen on their behalf. This stuff is complicated. But I had the conversation with my spouse, who's a lawyer, and whose intuitive reaction back to me was, why should doctors be so special that you should be the only person in the world who doesn't have to write anything down when you do your jobs? Like, in law, I have to spend all of my days in front of the computer. I don't get to just, waltz in front of the judge and, put on my gowns and give a song and dance and leave. I have to write the factums, and I have to read the stuff, and I have to do the documentation, and I have to submit the written arguments, and I have to, everybody, you know, so it may be actually that when we use the kind of physician exceptionalism argument that we miss that this is a big social problem, like actually much bigger than just medicine or healthcare, and that it applies across many, many other sectors and industries, and perhaps some of the solutions then we can look to other industries to try to figure out what they are. And the hope, of course, is that AI will fix all of this for us, right? Because, you know, the computer will just know I mean, I don't know how that can happen, but the computer will just know what it is that, you know, the first 10 things, and then you just need to kind of parachute in at the end. I guess my point is simply to say I acknowledge and agree with you that this is a very important issue. I don't have the answers, but I don't think that it is solely a healthcare or medical practice or primary care issue.
So I've spent the last third of my career practicing and teaching and being a patient in Canada after spending the first 2/3 of it in the United States. And after that experience, it sank in slowly because, you know, a little slow on the uptake, but I finally understood, I think, that there's a very fundamental difference between the US healthcare system and the Canadian system, and for that matter, all other Western systems. In Canada, the healthcare system is designed to get people the healthcare they need, however imperfect.